Thank you. Thank you all for coming here. Thank you to Terry and Transverse Myelitis Association for inviting me here. So I'm a neuroimmunologist. I moved to Montana, to Billings, about 10 months ago. And I trained in multiple sclerosis and rare neurologic disorders in University of Texas, Dallas. And okay, here's my disclosures slide. Also, my fellowship training in Texas was funded by the National MS Society and Genzyme. And my other disclosure is at times you might get the sense that I'm citing examples from personal experience. So my sister has multiple sclerosis. And at that time when she was diagnosed, I've sat in audiences like this. And it's also inflammatory disorder of the brain, spinal cord, and eye. And it happens to be rare in Pakistan, where I'm from. So I kind of have a little bit of experience being a family member of somebody with a rare neuroimmunologic disorder where I lived. So my objectives today are to kind of talk about why patients with an attack, autoimmune attack on their spinal cord, experience certain symptoms. What are the strategies we can use to manage them? And my ultimate goal here is to kind of enable patients and families to better understand the symptoms and what can be done about them, so that you can go on to better advocate for yourselves as you navigate the healthcare system and life in general. Before I started, I wanted to say the whole goal of symptom management is to make sure that we do everything we can to help all the problems the person is experiencing, but that's not the ultimate goal. The ultimate goal always is to make sure that we help in every way we can to encourage patients to lead a fulfilling life, to have goals, and help educate their families so they have more understanding at home, help educate their workplace if needed, and also to kind of set them free to still have dreams and hopes and goals in spite of this one thing that happened to them. So it's very critical for our patients to have support at home, with their families, workplace, and also to have a healthcare team that has experience with the condition they have in managing it and is aware of the resources that they can use and makes them available to them. Transverse Myelitis Association is one such resource that I'm using a lot for my patients in Montana because they tend to be very, very isolated. So in terms of some of the symptoms that can come from spinal cord injury, it says non-traumatic here. A lot of them we share with traumatic spinal cord injury as well. And I'll just read through them. Everybody here is probably quite aware, familiar with those. Sensory issues like numbness, tingling, heaviness, meaning weakness, tightness, spasticity, difficulty with walking, heat sensitivity, issues with mood or cognition, pain, fatigue, bladder, bowel, sexual issues, or autonomic system issues. And some of them I'm going to talk about in a little bit of detail, but some of them actually let me go back. Doesn't let me go back? It does. So the ones in bold here are the ones that will be discussed in detail after my talk. Pain, that you have a talk here today on pain, on fatigue, and autonomic symptoms. That includes bladder, bowel, and sexual issues. So when we're talking about each symptom, I want to talk about why, as far as we know, it happens, and what are the multiple strategies that are used to manage that individual symptom. But then also I want to talk about a little bit about in every individual's patient, there are more than one symptoms. And often we look for strategies where we can find one intervention which can help with multiple symptoms so that our patient has less to do and has less side effects. So that's also very, very important. And I'll try to illustrate as we go with an example case. So just before we launch into symptoms of the spinal cord, a little bit about the anatomy of the spinal cord. So here you see the brain and then the spinal cord, and you can see how small I'm trying to see if I can see, yeah. How small the spinal cord is compared to the brain. And I put it here to kind of, the point being that the brain is much bigger. It's common to have attack or silent lesions in the brain that you don't know of. The spinal cord is much smaller. Everything important is kind of close together, and that is why a single attack on the spinal cord can bring out a lot of symptoms, because everything, motor, sensory, bowel, bladder, is very close together in a small place. So depending on where your attack in the spinal cord is, you can experience different symptoms. So this purple part is the cervical spinal cord. Then green is thoracic spinal cord. And then in the end, in orange or blue, you have the tip of the spinal cord, which we call conus medullaris. And then you see this nerves going out of the spinal cord, going down, kind of like a horse tail. That's why we call it cauda equina. So depending on where on the length of the spinal cord the attack is, you can experience different symptoms. So higher up, if it's in the purple part, the cervical spinal cord, you can have symptoms of the arm. So this kind of shows the sensory dermatomes in the arm, and they're all coming from the cervical spinal cord. And if you have an attack of the spinal cord, in the green area or the orange-blue area, you can have symptoms in the legs. And this is the dermatomes of the leg. They're coming from the lower part of the spinal cord. And usually, injury to the spinal cord can affect any level, the level where it's at and below. So if you have a lower spinal cord problem, it's unlikely you'll have arm symptoms. So the attack, where the attack is along the length of the spinal cord is important. The other thing that's important is where is the attack if you take a cross-section of the spinal cord? Which fibers is it catching? Where is the attack? So this is a cross-section of the spinal cord. And you see the brown stuff here, H-shaped, that's the gray matter of the spinal cord. And then you see all the yellow stuff around it, it's the white matter of the spinal cord. The central, this H-shaped gray matter of the spinal cord is where all the nerve cells are lying. They're receiving sensory input, they're sending motor output, and they're surrounded by all this white matter. White matter is mostly it's nerve fibers and not the nerve cells. And depending on, we tend to classify transverse myelitis. Is it gray matter predominant? Is it just white matter? Is it a combination of both? And that can sometimes give us some clues. And with the AFM cases recently, there was some talk about AFM that's affecting the gray matter as well, sometimes exclusively as well. And then, so when we look at the white matter of the spinal cord, there are different tracks here. And depending on where you get the attack, you can have different symptoms. So an attack here would cause some sensory symptoms. Here, this is a tract taking information about pain and temperature. This is a tract taking information out to your muscles, so it's involved with movement. So depending on which nerve fibers the attack involves, that can affect the symptoms you have. And then whether it's one-sided or both. And this shows it's not as simple as I was just saying. There are a lot of tracks involved. The light green ones are the ones that are taking information up to the brain. The dark green ones are that are taking information down, and there are certain that are bidirectional as well. So depending on where the attack is, in terms of the length of the spinal cord, and then also in the cross-section, which fibers are affected, you can have different symptoms. Also, the other thing that matters is how severe the attack is, because that can affect recovery. So here you see a nerve cell, and here's a nerve fiber coming out, and this is the myelin coating the nerve fiber that makes nerve conduction efficient. And a lot of times in multiple sclerosis, transverse myelitis, NMO, there's an attack on the nerve fiber, and depending on the extent of the attack, it can determine how severe it is. So in certain cases, it's not just the myelin, the nerve fiber itself can also be cut or damaged. So we're back to the same symptoms now. And so here's just an example to help us go over some symptoms. So it's a typical case that we often see. A 21-year-old right-handed Caucasian woman woke up with numbness in her feet. Over the next few days, this ascended to her waist level. She also noticed legs were heavy, and she had retention of urine in her bladder. So it's a kind of a typical case that we would see for an attack on the spinal cord. And the symptoms we see here are numbness, weakness in the legs, bladder symptoms. She was treated with steroids, and 3 months later, she was left with some burning, pain, weakness, and tightness in her legs, some bladder issues, and she had heat sensitivity and fatigue. So these are the symptoms that she experienced. So a single attack on the spinal cord can give you a lot of different symptoms, simply because so many things are close together in the spinal cord. And we'll start off by talking about a few of the different symptoms, what causes the symptoms, management strategies, and overall goals, overall concepts of symptom management. So we try to use multiple strategies with each symptom, and I'll describe them as we go along. And we also, when we're looking at the patient as a whole, we try to find strategies that can help multiple issues in that patient, like pain and spasticity, together with one technique. So let's talk about spasticity first. It's the tightness. And a lot of times when you go to a clinic to see your doctor, they're examining you, and they ask you to keep your arms or legs loose, and they're moving them about. And you can see if they move it slowly, they can move you more. And if they move you faster, the resistance increases. That's when they're testing spasticity. Spasticity is resistance of the muscle or a group of muscles to externally imposed stretching. And it's velocity dependent, meaning speed dependent. As you move the limb faster, the resistance increases. What does it mean for the patient? It can feel as tightness, stiffness, transient cramping, or transient jerky movements of your limbs. Often happens in the evening or at night. If it's really severe, and we can do physical therapy even then to prevent it, but in some cases, joint contractures can happen, inability to move a joint. So how does spasticity happen? In terms of mechanism, you see it's the same spinal cord here. This is the muscle, and this is input from the muscle going to the spinal cord, and the nerve cell in the spinal cord sends. So this was sensory input from the muscle to the spinal cord. The spinal cord simply sends out a motor input to the muscle to contract. So when the muscle stretches, it sends information to the spinal cord. The spinal cord asks the muscle to contract. That's what we're testing when we check your reflex in the clinic. So we tap a muscle tendon, and you get the input to the spinal cord. The spinal cord tells the muscle to contract, and your knee jerks or your arm jerks. What happens in injury to the spinal cord that can cause spasticity is that this reflex has certain checking control systems on it, and those can be damaged in attack on the spinal cord. For instance, there are fibers coming from the brain down to the spinal cord that inhibit this reflex. Those fibers can be damaged, and that's why it becomes more active. You can also have certain cells within the spinal cord itself that are keeping a check on this reflex. Those can be damaged. You can also have, you can also have hyperexcitability of the cells sending the information to the muscle to contract, and that would cause the same thing. So usually it's a combination of all these things that makes a certain group of muscles very, very contracted, tight, and severe. If it's very, very severe, the spasticity over time can lead to results in muscle tissue itself. It becomes less elastic if it doesn't move, it's less elastic. That's when there can be fixed contractures. So physical therapy, certainly moving the muscle around, can help prevent those. So how does spasticity affect the patients themselves? Well, they can have difficulty with mobility. They can have involuntary, either cramp-like spasms or involuntary movements. Dexterity can be difficult, and they can get fatigued more easily when using that muscle group. They can have pain from it. And what we see in the clinic is the overactive reflexes, jerky, knee jerk, or arm jerk. Spasticity can cause issues, so it's important to treat. It can cause contractures, or in kids, it can cause scoliosis because they're still growing. You can have bowel, bladder, or sexual issue problems from that as well. Difficulty with transfers, and one big issue is spasticity can make it more difficult for you to move. If somebody is not moving, then they're at risk of skin breakdown and clots in the vein, or if you're not weight-bearing, you can have bone breakdown or osteoporosis. However, spasticity is not all bad news. It can help with certain things. It kind of makes it easier to transfer because you have a lot contracted muscle, and if you stand, it seems strong, and it makes it easier to transfer. It can make it easier to ambulate. If you have spasticity in the trunk muscles, it can improve balance when you're sitting. So when treating, we have to be very careful to not over-treat and cause weakness. So how do we treat spasticity? It's a multidimensional approach. I'll get it right eventually. Okay. So it's a multidimensional approach. And that's the key here with all the things that I talk about. It's a multidimensional approach. So that's why it's important to go to people who are used to treating these conditions, because the answer is never just medications. So spasticity can be worsened by certain triggers. We have to find out and inform people about them and avoid them. Medications, there are certain functional things we can do, and there are procedures and surgical things we can do. So what are the triggers for spasticity? The most common one is infection. Somebody with transverse myelitis has weakness in their legs, and they have tightness in their legs, and it was a one-time attack, yet in the past couple of weeks they're having more tightness. A lot of times the most common reason is an infection, and infections can be silent in patients with spinal cord attacks because bladder sensation is not 100%. So you can have a urinary tract infection without knowing about it, and it is very, very important to treat that infection because it can spread to the blood if you don't treat it. So we always check for infections in patients who have worsening of symptoms. And I'll talk about that, why it worsens a little bit later. What else can trigger spasticity? If you're in pain from any reason, that can make spasticity worse. Constipation, dehydration, restrictive clothing, a lot of things can make it worse. So we always have to ask patients these questions to see the bigger picture and not just prescribe medications. There are many medications that work well for spasticity. There are different groups. So one common one is we use centrally acting antispasmodics like Baclofen and tizanidine. These can be sedating. So if patients don't tolerate them because of sedation, we use another one called dantrolene. That's not sedating. And this list can go on. There are many other things to do. But this is just an example. Then you have other medications like anxiolytics, benzodiazepines. I've listed 2 here, clonazepam and diazepam. They can help as well. And also these we are more likely to use, for example, clonazepam here. It works not just for spasticity, it works for if somebody has restless leg syndrome, it works for anxiety, it works for jerky movements, it works really well for jerky movements of the legs that a lot of our patients experience at night. So we see what else is going on in an individual patient, and then we choose a medication. Anti-epileptics can work well for certain kind of spasms, and they work well for neuropathic pain too. So those, if somebody's having pain and spasms, we can often prescribe those. And then if needed, stretching, stretching and physical therapy are extremely important. So not just prescribing medications, and Janet will talk about the rehab part of it later, but stretching, physical therapy, rehab, those are extremely important, and we need help from our rehab providers to help us with that. And then sometimes if there's a lot of spasticity somewhere, for instance in the hand, it's curling and splinting, bracing, those things can help. So also Botox injections can help. If it's spasticity in a particular group of muscles that we need to address, which is, for instance, affecting walking, because you can't do Botox injections everywhere. So it's when we're talking about dealing with a particular spasticity issue, Botox injections are very useful. And how does it work? We inject Botox into a particular muscle, and Botox injections prevent release of chemicals from the nerve to the muscle that cause the muscle to contract. So we inject the Botox, the muscle doesn't contract as much, and it helps with spasticity. It's good because it's non-sedating, and it works in a particular group of muscles. If somebody has a lot of spasticity in the leg and not much otherwise, then you can just address it by injections. It's fairly rapid in onset. It's got, as always, as with everything, it's got certain problems too. It wears off usually about 3 months after the injection, can be expensive. Some people, it works well for a number of years, and then they develop antibodies to it, and it doesn't work as well. And also very important, if you over-treat spasticity, you'll have weakness. So in certain people, if you give them a big dose in the beginning, they can be weak. Good thing is it goes away in a couple of months, but then walking and transfers can become more difficult. And then in certain, I think I figured it out, a point here when changing slides. So here's an example of a case. So it could be our same patient, but if there's a lot of spasticity in her foot, for instance, and in the back of the leg, and she can't lift this foot, and then she has to usually swing her leg because she can't clear the ground. And it's all because of increased muscle contraction here, not all, but partly. Then you can do a Botox injection here, and you have to follow it. It's a multidimensional approach, so nothing by itself works, or is sufficient. So you inject Botox here, follow it up with aggressive stretching, and so you mobilize the foot here more, and then maybe use a foot device because her foot is weak so that she can walk better. That helps her lift her foot. So it's all multiple steps to address the same thing. And in certain patients who've got especially very severe lower extremity spasticity, Baclofen pumps can be implanted, and these can be very helpful. So a needle can be used to fill the pump at the port here, and then there's a catheter that goes into the spinal canal. And these can work really well for certain patients. Usually it's advisable to check in that patient. You inject Baclofen just like a injection into the spinal canal, like a spinal tap, and you see if they respond to this way of giving them Baclofen. If they respond, then we do the implantation of the pump. The good thing about Baclofen pumps is the lower dose of Baclofen is used, so it's less sedating. And there are certain problems they can have too. If the pump suddenly stops working, then Baclofen is not something that you should stop cold turkey. They can have withdrawal symptoms. And of course, anytime there's something implanted in the body, you are at risk of infections. You have to refill the pump as well. So in Montana right now I have, and in many parts of the country, access is a problem. So I have one person coming in from Seattle taking care of all my Baclofen pumps. In bigger cities, it's easier. Sometimes if spasticity is really bad, surgical tendon releases can help, tendon lengthening can help, and there's another procedure called dorsal root rhizotomy that can help. So the bottom line here is there are multiple things that are done to address every symptom. So for instance, in our patient, we could do the injection of botox into her back of the leg. Then we got to follow it with attempts to lengthen her tendon through aggressive stretching. Then we got to give her something to lift her foot because her foot is weak, and orthotic devices this can help. And then she might still need, for her spasticity, an oral agent like Baclofen. And then if she's still having jerky movements of her leg at night, she might end up needing clonazepam at bedtime for jerky movements of her legs. So it's multiple things that every patient need, and it's a hard balance to strike, keeping in mind that we want to treat symptoms. Treating symptoms make a huge difference in the quality of life of patients, but we don't want to give them side effects. So it's a hard balance. It takes a lot of to and fro between the doctor and the patient to figure it out, and this just summarizes multiple strategies are used to manage individual symptoms. And then second point is we attempt to use strategies that help more than one symptom in the same patient. For instance, so same slide, I just added something at the end. So clonazepam was used for phasic jerks and spasms. Well, what if the person also has restless leg syndrome and sleep initiation problems? Well, clonazepam helps with those too. So then I would be more likely to use it in that person because it's addressing multiple symptoms. So that's the same point here. So the symptom management is a lot of hit and trial. Somebody described it as French cooking. You try different things. Do not get disappointed if the first strategy fails. It's hard to predict for any doctor, any provider, what will work in an individual patient. For every symptom, there's a long list of things you can try, and it's a little bit of hit and trial. Response to medications can depend on the time you take your dose. It can depend on what dose you're on. It can depend how quickly you go up. If you go up very quickly, you're likely to encounter more side effects. So sometimes we go up slowly. It doesn't mean we expect the first dose to work. It's just that we go up slowly so that you are less likely to have side effects. And before we declare a medication as a failure, that it doesn't help you, it's important to let it go up to a good dose. If it works at a dose, great. Otherwise, you go up to either the maximum dose or where it starts causing side effects in you. So if somebody tells me gabapentin didn't work in me or Neurontin didn't work in me, I always ask them, what dose were you on? Why didn't it work? Did you hit side effects or did you just not titrate it up enough? So And then I learned through my training never to make too many changes at the same time. I put that poor patient on so many different things. If you do it all at once here in this slide, then they're going to have side effects, and you won't know what side effect is coming from what medication, what is helping you. This is very patient stepwise process. So you can know what's working, what's causing side effects. So let's talk about gait next, walking. Now, walking problems can happen from weakness. They can happen from spasticity, which we just talked about, fatigue. They can happen from heat sensitivity, pain, sensory issues. If you don't know where your leg is in space, it's hard to walk. So a lot of times weakness can be in lifting your leg here and lifting your foot here in a lot of our patients. And they can have certain kind of walking patterns where they're having difficulty lifting this foot. So now they have to swing the leg to clear the foot off the ground. Sometimes people have weakness in a certain set of muscles that when they walk, their pelvic becomes oblique. And that's all a lot of altered gait mechanics, meaning that's not how we're supposed to walk. That process puts stress on certain kinds of our hip or knee or back from walking abnormally. And a lot of times patients also have knee pain because their knee hyperextends. So that can all result in tripping, falling. Walking becomes a lot of hard work, which people who don't have walking problems don't realize. Just walking from a parking lot to an office can be a lot of work for somebody who has issues. And of course, it can lead to falls, which can be dangerous. So how do we manage gait problems? We do strengthening through rehab, physical therapy, exercise. We do all the things I talked about to help with spasticity. Some people need orthotic foot devices or assistance with walking. But we also avoid heat, because most people in this room know heat makes everything worse. And I'll just talk about why in a second. And then there's another thing that can sometimes help that we know from the world of MS. It can help with walking, and I'll talk about that. It's a potassium channel blocker that can also help walking. So multiple things, again, can be done for every single symptom. So what is heat sensitivity? Why do we feel worse when we are overheated? This is a paper I'm citing from done in Dallas. So it's coming from the world of MS, but it's very similar issues in transverse myelitis, neuromyelitis optica as well. So this is a normal, healthy-looking nerve fiber. And it's got that myelin around it. And if there's an attack on the myelin or the nerve fiber itself, nerve conduction is not that efficient anymore. So that's the nerve conduction helps you with sensory information going to your brain. It helps you with walking. It helps you with bladder function, bowel function, vision, everything. So if you have an attack on your either myelin surrounding the nerve or on the nerve fiber itself, nerve conduction is not very efficient to start off. What happens when you're overheated? Well, when you're overheated, we're just zooming into from this. This is a very big view of a nerve fiber. Now we're zooming into individual channels. So on the nerve fiber, nerve conduction happens through transfer of sodium and potassium. These are charged ions, particles. So that's how nerve conduction happens. And basically what happens is if body temperature rises, and all of us, not just in patients with TM or MS or NMO, there's sodium channel failure, there's excessive potassium going out of the nerve fibers, and that makes nerve conduction less efficient. So if you have problems pre-existing from either, say, TM, and now your body temperature rises because you were mowing your lawn in the heat, or you exercised too much, or you had a recent vaccination or a fever, or perimenstrual, or you have an infection that you know of, or a silent infection. It's very important to remember silent infections of the urinary tract are very common. So there's rise in body temperature from that, and now your nerve conduction is slower, less efficient, and all your old symptoms that you've had from TM, they're going to become more prominent. The same thing if you were outside exposed to heat with, say, your family member, they have a rise in body temperature too, but they can compensate for it. But in you, because nerve conduction is not efficient, there's damage, it's compromised, your old symptoms come back. It's reversible. That's the important thing to know. And it's not a new attack, it's reversible. What do you do about it? You cool down, you treat the infection, and it gets better with time. It's very important to know because it can be very scary. It feels like a new attack. And it's very important to know in you what things lead to rise in body temperature so that you can find solutions for it. Drinking cold water, cooling vests. If heat sensitivity keeps you from playing tennis, maybe you can play it with a cooling vest and still do what you like to do, but find ways of addressing the problems. The other thing is potassium channel blockers. So same thing, potassium channel blockers here, they prolong nerve conduction potentials, and they make nerve conduction, to put it simply, more efficient. So in people who are having symptoms because of slow nerve conduction, it's sometimes if you give them potassium channel blockers, nerve conduction becomes faster, walking gets better, or any of the symptoms. It was studied in MS for walking, but it can affect heat sensitivity, it can affect fatigue, it can affect balance, walking, anything really, if that person responds to a potassium channel blocker. Potassium channel blockers don't work, not everybody is a responder, but it's always worth checking if it helps a particular patient. In transverse myelitis and NMO, because you're not under the umbrella of multiple sclerosis, it's sometimes hard to get the medication, this one, approved, dalfampridine. But because the insurance company says there's no trial, there was a trial actually in TM. They often don't go, the results don't help us much with the study though. A lot of times we use this compounded 4-AP, and that's easy to get. So our patient, same case, so numbness, spasticity, tightness in the legs, weakness in the legs, bladder symptoms, fatigue, heat sensitivity. And so based on what we just talked about, we could try, we don't need to stop here, right? We can try cooling strategies, teach her how to remain cool so that she can walk better. We can do a trial of potassium channel blockers. So all of that can really affect her quality of life. What about fatigue? I'm not going to talk a lot about fatigue because we have a talk coming up, but I can't help talking a little bit about it because it is extremely common in TM patients, in NMO patients, and it's a very quality of life affecting symptom that nobody can see. If you're not walking very well, people can see you not walk very well. Fatigue can really make you feel terrible and stop you from being able to do the things that you need to do, but other people cannot see it, and that can lead to problems, and it's very important to treat. Now, fatigue itself can cause a lot of other things. So word-finding difficulty is very common. Your ability to think can be affected. Processing speed can be slow. So people can be, in their work environment, can be embarrassed if they're giving a presentation, just finding the words, or at work they're always worried that cognitive issues, if they show up. But it's important to remember it's not always just primarily a cognitive issue. Just treating your fatigue might help make your word-finding difficulty go away. And also your thinking ability might just go away or get a lot better if you just treat the fatigue. Walking problems, if you're fatigued and walking already is so much work for you, it really makes walking worse too. Also, here I'm going to quote my own personal example. that was before I came into this field, but my sister already had MS, and she had her first manifestation of heat sensitivity and extreme fatigue in New York. And we were on a trip in New Hampshire. And I was like, so that sometimes if family members don't understand your symptom, it can lead to problems. And I was thinking, why is she being so not interacting with us, not talking to us? Does she have a mood problem? Is she mad at us? And all it was fatigue. So it's very important for us to bring in patients' family members into our office and tell them that if they're not interacting with you, don't feel like they're not talking to you, which they could be, but sometimes it's just from fatigue. Sometimes it's just from also if they're not helping out as much at home, it can be MS or TM or NMO cause a lot of fatigue issues. The good thing about fatigue is it's the most common symptom in our clinics. It's the most common reason people stop working or stop doing the things they want to do, but it is very, very treatable. It responds quite well to treatment. Before we put people on yet more medications, it's always important to make sure fatigue is often a lot of times because of the medications we use. So if we can take away some of those, or sometimes we can't, but spasticity and pain medications can cause fatigue. Sleep issues, if you're not sleeping because you have to get up every 2 hours to go to the restroom to urinate, or you're having painful spasms that are not letting you sleep, or you have bad nerve pain that's not letting you sleep, that can obviously is going to cause fatigue too. So addressing those can help. If you have sleep apnea, obviously that will cause fatigue too. So it's always important to make sure we just don't add a new medication. First, we got to go through everything to make sure other things are not contributing to your fatigue. Mood disorders can also look like they're giving you less energy. So treating those can also help. So fatigue management strategies, as much as possible, we try to avoid sedating agents and try to use one to address multiple issues like nerve pain and spasticity together instead of putting you on two separate medications. Treating your having to get up at night to go to the restroom, or treating your pain or spasms at night that interrupt your sleep is very important. Sometimes we often need to do a sleep study to make sure there's nothing else going on, but fatigue responds very well to medications. These are some of the ones that we use, and just treating your fatigue, it's very important to know, can just improve your walking, your word finding, your cognition, your perceived mood, your ability to function better and do the things you want to do. So same slide, but we could possibly consider adding fatigue medications, but you see how extensive our list is becoming. So we always want to make sure we're not adding unnecessary medications, that we can just fix the fatigue just by taking away some of the other things, or by fixing pain better, or having to get up at night better. So, and then I think, so pain, again, there's a whole lecture on pain. I'm not going to delve too much into it, but it can also be primary nerve pain, or it can be coming from your spasticity. Back pain and joint pain can come from your abnormal walking. There can be scoliosis issues. There can be pressure ulcers. All of those could cause pain. So what we do takes a lot of talking with patients, because it's not automatically, okay, somebody has pain, it's nerve pain, we got to talk to you, figure out what's going on. Some of the tracks we were not 100% sure, and there might be some of it in the next talk, but spinothalamic tract involvement, that's a tract in your spinal cord that can cause that, or can interrupt the information that's going to your brain, and that might be in part responsible for pain. We have different theories why our patients get pain. Some of it is, one is we sometimes say, there's lack of information to the brain because you're not getting as much sensory input to the brain, and the brain makes up for it by these perceived pain sensation. There's another theory that says there's a lot of misfiring or overfiring of the cells in your spinal cord that are injured, that's causing pain. but it's a very common symptom we see. So pain can interrupt your sleep, fatigue, it can cause mood issues, it can cause bowel, bladder, sexual issues, it can decrease your mobility because it's so painful to walk, which can cause you to have less exercise, gain weight. So it's all a complicated equation for us. Pain, we always have to make sure we're not missing contributing factors, and there are many medications that I'm sure you'll hear about in one of our next talks. It's not just medications that can help. Cognitive behavioral therapy, physical therapy, acupuncture, in certain cases, spinal cord stimulators can help. Same slide, but the list of medications is increasing, but again, we can fix one thing. So we can here ask the question, anticonvulsants, maybe they can help the person with pain, but also the spasms that we were talking about here, and maybe we can take away this or one of the other medications. So it's always a complicated equation. Mood issues, I'm running out of time here, so I'm going to... mood issues are very common. Again, we need to clarify why the person is having mood issues, and it's very important. Sometimes we don't take mood issues seriously to ask about suicidal ideation. It's a very common thing in MS, third leading cause of passing away, so we have to always make sure we address it. Either with ask about it, address it with either medications or psychotherapy, or just improving the support system if there's bullying at school, work doesn't understand what's going on, family has no idea what the patient's problems are, just addressing those can make mood a lot better. Cognitive issues. So there's a lot of Dr. Lana Harder in Dallas talks a lot about it with TM patients. But the first thing to remember is depression and fatigue can produce symptoms that sound like cognitive decline. And these are reversible if you treat the depression and fatigue. So formal neuropsych testing helps us clarify, is it a cognitive issue, or is it the depression or fatigue that's causing the issue? Cognitive dysfunction, academic issues, are seen in up to a third of the patients with TM, which is very surprising because it's not an attack on the brain. And these numbers are the same as pediatric MS patient numbers for cognitive issues. Not everybody has it, but TM patients can have some cognitive issues. Mostly it's attention, memory, and learning that's affected. The number is the same as for pediatric MS, so it's a third of the patients. Not everybody has it, doesn't have to be severe, but it's there, and it's surprising why, when the attack is in the spinal cord, there's cognitive issues. There's overlap between cognitive performance and fatigue, and it was a very small study that they did. They didn't find any overlap with cognitive performance and mood or medication, but it's a very small study. So if people have cognitive issues, the neuropsych person works really closely with them to come up with compensatory strategies for it. Still haven't learned. I'm still trying to flip slides over there. So I'm finishing, I promise. So the bottom line of sharing these is to get the point across that multiple strategies are used to manage each individual symptom. Also, at the same time, we have to attempt to use strategies that help multiple symptoms at the same time. So patients have less side effects, less things to do, less medications to take. We need a very big team for our patients. That's why going to individual centers that specialize in this makes a huge difference, because they have rehab doctors, rehab providers, physical therapists. We need help from urologists, sometimes gastroenterologists, neuropsych people, psychiatrists, ophthalmology, primary care providers are a big part of our team, and also help from patients' family members, because they're the support system for the patients. Sometimes we need to help or make an intervention at work or in school, because they just don't understand the problems the patient faces. We've gone over this already. It's all hit and trial. Do not get disappointed. It takes time, and meticulously, if you commit to symptom management, you can really change people's lives and see good improvements and never make too many changes at the same time. Take-home points, my hope was to help you better understand some of the mechanisms behind certain symptoms and the different management strategies, and then the importance of having a whole team of specialists or experienced multidisciplinary team, and attempt minimal interventions to address maximum symptoms. And it's critical for us as we try to help our patients with optimal symptom management, but also to do the things they want to do in life, to have a very good support system with family, healthcare team, and also Transverse Myelitis Association is a big resource I use for my patients. And also sometimes we work support or school helping them understand our patients' problems is very, very helpful. Thank you.